Hello, everyone, and good evening. It's a Friday evening, and welcome to our live event tonight. It's good to be back as always. I'm your host, Caroline, and as you can see, we do have another special guest with us tonight, and this is Dr. Evangelos Papanikolaou. Hello, Dr. Evangelos. How are you feeling tonight? Hope you are well.
Good evening, everybody. We are pleased to have you here and we are speaking from Greece, from Assisting Nature. And we would like to thank Caroline and her partners for letting us share our knowledge.
Yes, we are definitely happy to have you with us once again. Thank you so much from whole team and of course from all of our patients indeed as well for joining our Stronger Together events. Of course, as you know, our main topic for those events is successful IVF treatment after failed attempts. And as you know, we are here every single day from Monday to Friday to support you, to give you an opportunity to meet top fertility experts like Dr. Papanikolaou, and of course, just to answer some of your questions. And we will start with the doctor's presentation, and afterwards it will be time for your questions. So as always, put them in the chat section during the presentation or afterwards, and I'm sure Dr. Papanikolaou will be happy to answer them for you. And I just also want to mention that again, this is a Friday. That means this is Greece as a promoting destination. We promote this destination of 2021, and I definitely want to mention that Dr. Papanikolaou is also part of it. He is the ambassadors of this whole initiative as well. As you know, every single Friday we are bringing some top experts from Greece, so you can so they can share their knowledge, and of course you can meet them this way, of course, and then ask your questions, of course, as well. And before we begin, I also want to mention, as you can see, there are other ambassadors and partners that have been supporting our Stronger Together initiative as well from the very, very beginning. We started in March and we are going strong indeed with all those events. So huge thanks for their constant support. And now it is definitely time to start our topic. And this is definitely an interesting but also quite difficult topic, which is pre-implantation genetic diagnosis for the treatment of repeated implantation failure in IVF. And of course, Dr. Papanikolaou will start off with his presentation. All right, are you ready to begin then?
Yes, Caroline. Good evening,
Wonderful.
everyone. Good evening, everyone. Again, we tonight will discuss how pre-implantation genetic diagnosis can assist us and, of course, our patients that they are failing multiple times in previous IVF treatments. So, actually, what bonds reproductive specialists, geneticists, and embryologists is the aim of higher success in IVF. And unfortunately, although many times we achieve the establishment of a pregnancy, on the other hand, also a lot of times, up to 50%, we face implantation failure or even miscarriage. So it's not only to achieve the pregnancy, you have to achieve a live birth at the end. So there are a lot of obstacles until that beautiful end. And one obstacle is the implantation failure. And actually, we have two scenarios of implantation failure. A real implantation failure means that we have no implantation with negative ACG test, or we have a slight increasing ACG test that ends up with a biochemical pregnancy. Both of these situations can be defined as implantation failure, and recurrent implantation failure, RIF in our language. It means there are many definitions in the literature. However, lately we are getting closer to the definition of 3 high quality embryo transfers of more than 6 blastocysts. So, what might be the reason for recurrent implantation failure? The first reason, unfortunately, comes from the mother, and mainly the genetics of the oocyte. And the reason is that, as we will see later, the more the reproductive age of a lady is increasing, the higher the chances to have genetically abnormal eggs. So genetics is the main reason from the side of the mother, and then we have anatomical reasons, for example, uterine septa, and then we have thrombophilia, and the rest are in the proportion of 1%. For example, only 1% might have an immunological factor, although a lot of women tend to believe that their immunology is the reason of the failure. I can assure you that this is extremely rare. The same happens with infection. It's trend lately with all this microbiome of the uterus to blame subclinical endometritis for recurrent implantation failures, but I can tell you that this is not true, because the reality is that main is the embryo. Also, we have other factors that alter the endometrial receptivity. And for example, in these particular factors, we can change a bit the ability of the uterus to allow implantation of a blastocyst, either by performing hysteroscopical scratching or by inducing into the cavity, for example, growth factors. On the other hand, we have also the paternal effect. For example, if we have increased fragmentation rate on the sperm, or if they are heavy smokers, or if they have extremely low number of spermatozoa, we call it in our language severe oligostenospermia. And also we can blame the IVF protocol. It's true that not all the protocols are suiting each of us. That's why the reason for personalized medicine. And at the end also, the embryo might be the problem, either because from factors arising from the mother or from factors arising from the father. The problem of IVF today is that we cannot check the euploidy status of the eggs and the sperm and then to utilize them. We can do it, but we cannot utilize them afterwards. So, as you might have read, and I'm referring to our patients that they are guests tonight, the egg should be 23 and the sperm should be 23 chromosomes in order to have a viable 46 chromosomes embryo. This, in Greek terminology, it's called euploid, good structure egg, so euploid embryo. And when we have less or more chromosomes or part of a chromosome, then we have a situation called aneuploid. It means the opposite, that our embryo is not correct. And this not correctness of the embryo that we produce and at the end eventually we might transfer is that either it fails to implant, or even if it plants, we have early pregnancy miscarriage. And from a genetic analysis of the miscarried embryos, we know that more than 60% of them are genetically abnormal. Let's have a look again who might be the main reason. So the reason for abnormal embryo might start early on the oocyte, and as you can see, 80% of the abnormal embryos is due to advanced maternal age and problems in errors happening in oogenesis, only 2% in sperm, and also up to 20% might arise later. So we might have a normal egg and a normal sperm, but after the fertilization, the embryo has difficulties in dividing correct, and therefore we might face a lot of difficulties in keeping the embryo, its correct structure, genetic structure, and at the end we have an abnormal genetically embryo. And as we discussed earlier, the main reason is the advanced maternal age. The higher the maternal age, the higher the aneuploidy rate in the produced oocytes. And of course, the higher the aneuploidy rate, the lower the pregnancy rate that we can achieve. Also, you can see here that even if we transfer blastocysts, the pregnancy rate decreases by age, and the reason is that even if we transfer a good morphologically blastocyst after the age of 40, there is high chance, more than 70%, this blastocyst to be aneuploid, meaning not being complete 46 chromosomes. The structure and the number of chromosomes is not correct. And what are the most frequent aneuploidies? Of course, up to 50% is trisomy 21, and then it follows trisomy 18, 13, Turner syndrome, and other syndromes are less common because, as you can see, the main problem is with trisomy 21. So until 2000, we had only morphological criteria to implement in our selection of the embryos to be transferred. And the problem was that we had no clue about the genetic background of these embryos. So actually we were discussing and we were presenting nice images of the embryos to our patients, and at the end they had no pregnancy. And the reason is that in young women less than 35, up to 50% of excellent morphology embryos are aneuploid after performing genetic testing. Up to 2000, this information was really missing in the communication between doctors, fertility specialists, and the patients. And I do remember my professor discussing with a lot of patients in front of him, and he had nothing to explain because during the transfer they kept asking him, but why we failed? You told us that these embryos were excellent. And they were trying to identify different explanations to discuss and to explain this failure, how did arise. Fortunately for us, the new generation of embryologists and fertility specialists, we have preimplantation genetic diagnosis, and now we know that up to 50% of the embryos, of the top embryos, are genetically abnormal. And the nice thing is that irrespective of the age, if you have a normal and euploid blastocyst with 46 chromosomes, you see either if you are 30 or if you are 45, your chances to have a pregnancy is 45%. That means that one of the main advantages of performing genetic test is that if the lab calls you to come for a transfer, it means that you will have a baby probably by 50% probability, irrespective of your age. And although the first embryo biopsies were performing on day 3 embryos, lately we moved to day 5 embryo biopsy because we can obtain more cells, we can damage less the embryo because we take only a smaller part of the embryo out, and also we can perform this in really evoluting embryos and not to all of them. So it's another thing to perform an expensive test in 10 day 3 embryos, and it's much better to perform it at the end at 5 blastocysts, for example. So you lose less time and you spend less money. And although genetic test should be performed in the inner cell mass, where the actual embryo and human at the end arises, unfortunately we cannot do this, and we cannot ethical approval for doing this. So what we do at the end, we take some of the part of the embryo that at the end will become the placenta. So we don't touch the real embryo. We touch a small part of the trophectoderm that is meant to become later the placenta. And as you can see in this image, either an embryo can be completely euploid, mean both inner cell mass and the trophectoderm, or completely aneuploid, both inner cell mass and trophectoderm being abnormal, and sometimes the embryos are mosaic, so some cells are abnormal, and if they are abnormal in the trophectoderm, then you risk not to transfer this embryo because the inner cell mass might be normal. But 50% of the cases, the mosaicism exists in both trophectoderm and inner cell mass. And fortunately, in the beginning of preimplantation genetic diagnosis, we did not transfer mosaic embryos, and we were putting them in the bin for destroying them. But lately, after many nice studies, we have identified which categories of mosaic embryos can give a live birth, and up to 40% of the mosaic embryos, we do transfer them, and we still have nice deliveries. So the gold standard of preimplantation genetic screening that nowadays is called PGT-A, so is the trophectoderm day 5 biopsy. Then we vitrify the embryos. We are waiting for the result from the NGS machine, that it comes within 1 day up to 24 days, and then we select which embryos that we have already frozen are genetically normal, and we transfer them back either in a natural cycle or under the preparation with estrogens. So this has completely changed the history of IVF, because we really know what we transfer, and we don't say to our patients that we transfer a nice looking embryo, but we say we transfer a genetically good embryo, normal embryo. Because preimplantation genetic technique is still invasive, and there are a lot of efforts to make it non-invasive. For the moment, the golden standard is invasive. We try to identify which categories of patients might benefit the most out of preimplantation genetic diagnosis. And of course, the main categories: advanced maternal age, and then couples with severe male factor, with recurrent miscarriage, with recurrent implantation failure. I think these are the couples that benefit the most, and also couples that they have already known chromosomal abnormality, either if it's a structural abnormality or if it's a Klinefelter syndrome, for example. And the problem is that the patients, you don't really know which lab does perform this invasive technique with high standards, because it's better, because it's an invasive technique. If you don't know how to perform it well, it's better not to offer it to your patients. Otherwise, you harm their chances for becoming pregnant. And patients are in the weak position that they cannot really know who is performing this test scientifically and technically perfect. But if it is performed well, then you have precise genetic results and excellent IVF outcome. In order to keep our personnel always hot and in performing preimplantation genetic diagnosis, we do a lot of seminars in bovine blastocysts, for example. In order to increase our skills, we perform only trophectoderm biopsy, and we use only NGS. And if we detect a mosaicism, then after careful consideration of the literature and the advice of highly trained geneticists, we decide together with the patient whether to transfer or not a mosaic embryo. And our results for 2019, as you can see, the live birth rate is above 60%, even 90% if you are 42 to 45, because there are very few the women that they have normal embryos. Don't forget this, but you can see that the majority of the patients, up to 70% of overall, once your embryologist calls you and tells you, hello, Mrs. whatever the name is, you have an Aneuploidy embryo and we can schedule your embryo transfer, then you can really be happy, because you might achieve a live birth rate more than 70%, irrespective of your age. The previous time when we had a webinar, this winter, last winter if I remember well, we presented some cases, because it makes the whole discussion a little bit more interactive. The first case is a female of 36 years old with normal sperm parameters, that in the first ICSI they had 9 blastocysts, that all of them, of course, they were frozen because of the fear of HSS. This lady, she had 5 negative results. One of them was even a spontaneous abortion after the heartbeat was noticed. So this lady, she had 5 negative feelings with single IVF. For this reason, we decided next time to offer her a preimplantation genetic diagnosis. And as you can see, she produced again 12 eggs, and we had 7 blastocysts that only 3 of them were euploid. And with the first single embryo transfer, we had immediately a live birth. That means that if, for example, we had performed preimplantation genetic diagnosis in the first ICSI and we had found that all these 9 blastocysts were abnormal, we should not perform any embryo transfer. Another case is a PCO lady that she had IVF because her husband has completely azoospermia, and we had to perform TESE, testicular sperm biopsy. So the first ICSI in another center, she had TESE and only 5 embryos at the end became blastocysts. That was a good number for sperm retrieved from the testicles. She had 3 FRET cycles without any result. So, in these young ladies that the husband has azoospermia, I'm telling them that they can try with their husband's sperm, although it's testicular, up to 2 or 3 times because they are really young and they can really rescue the problem or the abnormalities of the testicular origin of the sperm. And therefore, we suggested to perform preimplantation genetic screening, and again we had only 3 embryos that at the end were blastocysts, and 1 was euploid and 1 was mosaic. And first we transfer the euploid embryo, and now we have an ongoing pregnancy at 27 weeks. So you see that only 1 embryo was at the end euploid plus the 1 mosaic that we don't know. We will transfer it, of course, for a second child after she delivers. And really, this lady that she had 3 negative embryo transfers in her previous trial, she managed with the first transfer to become pregnant. And the last case that we had a relatively normal couple with a lady having an autoimmune syndrome that was multiple sclerosis, and the husband was normal, her AMH was relatively normal, and they had IUIs before, and this is 2 ICSI here, 2 IVF, all negative. So we discussed about genetic screening in their third IVF, and she produced 7 eggs. 5 of them ended into blastocysts. We did preimplantation genetic testing, and we had only 1 mosaic and 4 aneuploid blastocysts. That relatively explains the previous situation with all these failures. So, happily, this mosaic was transferable, and now we have an ongoing pregnancy. It's just a new pregnancy of 7 weeks, so actually we don't really know if it will end with a live birth, But I can tell you that one of the advantages of preimplantation genetic screening is that once you are pregnant, the chances of miscarriage is around only 5%, irrespective of your age again. So this lady, she has only 5 to 10% of losing this pregnancy. So let's cross our fingers, and if we are here next year, we can say that we had a delivery. So ending our presentation, recurrent implantation failure is a complex problem, mostly arising from the eggs, but also from the sperm, also from the embryo, plus some factors from the woman, anatomical factors, thromophilia factors, and very, very rare immunological or infectious factors. What we need, of course, we re-examine the couple, we deeply re-evaluate them, and after we identify or not identify an additional problem, only then we proceed with a next IVF protocol. That, especially in these cases, preimplantation genetic diagnosis really has a place, because this these couples, they need answers, and without genetic identity of the transferred embryo, what answers we might give? So, thank you very much for the moment, and we are more than happy to listen to any questions if they exist. Caroline.
As well as your presentation. Lots of interesting things you have said for sure. And thank you so much for bringing the real cases. It's true, it's always something that we are definitely looking at. So thank you for that. And well, there are plenty of questions ready. Okay. And let me just remind everyone that if you have any questions, go ahead and type those in. Our Q&A session is just starting right now. And the very first question is right here. So, what are the causes of more than 46 chromosomes in embryos? Causes of less than 46? Could high stimulation drugs be a cause?
The causes, as we discussed earlier, is mainly the incapability of the egg to divide his 46 chromosomes into two pairs of 23. So there is an internal incapability of the egg not to divide strictly half 23 and the other 23 to become the polar body. In the past, there was a lot of discussion whether high stimulation might be the cause. And there were some papers back in 2004 and 6 regarding this issue. The truth is that the higher the stimulation, the doctor retrieve more not mature eggs that at the end might divide into blastocysts, but these blastocysts will be abnormal. So the problem is not per se the drugs or the high stimulation, but that the problem is that we retrieve all the eggs, all the follicles, we aspirate all the follicles that we have in our ovaries, and of course, by this, we might end up with higher aneuploidy rate in that particular patient. But you have always to remember that if I'm a good responder and I produce a lot of eggs, at the end, I increase my chances to have also a normal length and at the end, maybe a normal embryo. So actually, high stimulation is not the real a causative agent, but only statistically might change this result, that's why we need a rational stimulation. And what does it mean rational? To produce as much as I can without any harm to my health. And we know that the perfect number of eggs is around 15. More than this, there is no benefit. Less than this, of course, you have lower chance of pregnancy. So the maximum is around 15, and we should aim our stimulation for this number, if it's possible.
Excellent. Thank you so much for the very first question and, of course, your thorough answer to this one. Next question is also ready. In your experience, what is the oldest woman you have treated with euploid embryos and healthy live birth?
The oldest woman that we have one euploid embryo and have a live birth was 45. So the chances to have an euploid embryo at the age of 45, as you know, is 1%. This 1% is reality. So if you have 100 ladies of 45, at the end, one of them, she will become pregnant.
All right. Thank you so much for explanation, of course, for that example as well. So do you know what is the cost for PGT testing?
Of course, with NGS and with the technique that we perform our biopsy, the cost is 1,000 euros for the biopsy itself in Greece, plus 250 euros per embryo. So if you have one blastocyst, then you will pay 1,250 euros. If you have 4 blastocysts, you will pay 2,000 extra euros.
Wonderful. Thank you so much for the clarification. And of course, next question is up. At the beginning, we had 18 oocytes that fertilized. However, at age 6, only 3 suitable for PGS. Why would only 3 be suitable for PGS? Have they got to be very good embryo for PGS testing?
Uh, we do not biopsy everything, of course, so the blastocyst should be above BLA in order to be tested. The problem is that already here the embryos became blastocysts at day 6. That means that they were already very late in their development. So probably on day 6, if you have, even if the blastocyst is perfect, the chances of being euploid is only 10%. So it does not mean that I have an excellent blastocyst on day 6, that this blastocyst is normal. So in this particular couple, the problem might arise either from the high number of eggs, maybe this lady was a PCO lady, or from the poor quality of the sperm, or from the poor quality of the stimulation. For example, if they retrieve their eggs earlier, then you might end with this late development at the blastocyst stage.
Excellent. Once again, thank you so much for explaining this to us as well. Next question is also ready. Would it be possible to send you a PGD24 report and the photos to get your opinion which ones could be possibly transferred first into my surrogate?
Definitely, Ross. You can send this information to our excellent staff, embryologist, I mean, Mrs. Timotheou and Mrs. Chartomatsidou, and they can really advise you which might be the first option, because I do guess that you agree that you have to transfer one by one your blastocysts to the surrogate
And
in
wonderful,
order
thank
to
you.
avoid in order to avoid any complications later during the labor.
All right. Of course. Thank you so much. And of course, there is a yes. That's right. Okay, just so you know, of course, I will send you the link where you are able to get in touch with Dr. Vangos and his team as well. Okay, this is an option. There is a contact button there, and it will be forwarded straight to the team, of course, as well. And let's have a look. Of course, next question is ready as well. There is like two parts, okay? Because it's what about mosaics and what are the criteria you use to select mosaic embryo for transfer?
As I explained before, mosaic is also a Greek word. It means that if the blastocyst has 100 cells, 20 of them might be abnormal and 80 normal. Or the opposite, 20 might be abnormal and only 20 are normal. Mosaicism, in some way, is a normal procedure in the development of the blastocyst. It looks strange, but actually it's a normal procedure. So the embryo, trying to avoid of the abnormal cells, because mistakes do happen in the best families, so they try to abort these abnormal cells to the trophectoderm, that unfortunately we do the biopsy. So actually the trophectoderm sometimes might be the protection shield or the protection garbage bin of the embryo itself, where the abnormal cells are deposited. So this is the explanation of mosaicism. On the other hand, of course, mosaicism half of the times do indicate the incapability of the embryo really to divide in a correct manner its cells. So, and this might be the problem, that at the end, half of the embryo is abnormal and half is normal, and this embryo cannot really give life to a human. So the criteria that you use to select a mosaic is that if we have less than 10% mosaicism and in specific chromosomes, then our genetist advised for them to be transferred, and you can find these informations in our leaflets on internet.
Wonderful. Thank you once more for answering this question. Next question is, so do women over 42 often have enough embryos to perform PGD? You talked about 5 embryos.
I talked about 5 or 6 embryos in total from different IVF in order to define that someone has a recurrent implantation failure. So actually, we only need one, my dear, as you know. So the more we have, if we are over 42, of course, the better for our chances to find an euploid embryo as well. But on the other hand, if I'm 42 and my AMH is low, and if I take medications, I do not produce more than 2 eggs, then we can do several natural cycle IVF, and we can deposit 2 or 3 blastocysts after 9 natural cycles, for example, and to do genetic test in these 3 blastocysts after 1 year of trying. That should be the maximum, so our doctor needs to put a threshold up to when shall I try, and out of these 2 or 3 blastocysts, if I'm lucky, then I can have a normal blastocyst, and at the age of 42, this probability is around 15%.
And excellent, thank you once more for that. Next question is from Maria. I'm choosing between doing NGS and another method of PGS where the transfer is the same month. How much higher is the risk of Down syndrome if I do regular PGS instead of the new NGS and the miscarriage and implantation failure? Right.
Maria, there is no reason for fresh transfer anymore because actually, as we know, the endometrium is always better outside the stimulation. So, on the other hand, NGS is the excellent platform for the moment for identifying abnormalities. So, the only reason to perform the old way with microarrays of PGS is when I have frozen embryos, for example, from another trial or from another center, and I do transfer them in another center, and I want to know if I have 4 blastocysts, for example, and I did use, if, for example, I had 7 blastocysts in another center, and I transferred the 4 of them, and I had 0 pregnancy, and I don't want to continue, and I still have these 3 blastocysts. If I really want to know if these 3 blastocysts are genetically normal, only then we can do this old way of PGS on day 5 and to transfer them next day on day 6.
All right, and there is another question from Maria, so let me go straight to that one. So would clinics be willing to do regular PGS on some embryos for immediate transfer and NGS on the rest and freeze? I have PCOS, so might get many.
So it's up to you. After thorough discussion with your fertility specialist and your senior embryologist, if you have a lot of eggs and a lot of, let's say we have 10 blastocysts, Maria, then we freeze, let's say, 4 of the blastocysts without doing PGS, and we do NGS on the rest of them, waiting for the result. So I do really not consent for fresh embryo transfer and fresh, let's say, PGS on women, especially like you with polycystic ovaries. It's a malpractice.
All right, thank you so much for that then, of course, as well. And there are like few questions left, 3 to be exact. So we will be slowly finishing. But of course, if you have any questions, go ahead and type those in. And here's the answer from Maria. Actually, thank you. I'll do NGS then. All right.
I
All
need
right.
you to send us an email afterwards once you're pregnant.
Yes, of course, you can do that, and I'm sure you will get even more details indeed as well. So, okay, let's have a look. So, could ubiquinol help to fortify the eggs?
I don't think of all these additives that at the end can help the quality of the eggs. I think within the coming 50 years we will have a real pharmaceutical agent that makes these meiotic errors not to happen anymore in the egg, and a lot of women within the next 50 years will not need any more IVF because they will produce euploid eggs and euploid embryos.
All right, understood. Of course, thank you so much for commenting that as well. Of course, here. Okay, next question is up. For which reason sometimes embryos do not reach blastocyst stage? Is it because of the quality of the egg? I did 4 IVF. The first I had 4 blastocysts. I was 30, and the 3 others IVF I got only 4 embryos in total, and they always transferred day 2 or 3. All of them were negative. And sorry, follow up. I never got them tested, but for next IVF, I would definitely ask to have them tested.
Priscilla, you should have done this much earlier, first of all, preimplantation genetic testing. Sometimes is the sperm and sometimes is the egg. So the embryologists really know from the beginning if the eggs they don't look really good, they are dark with a lot of kenotopes or microvacuoles, they can say from the beginning that this lady do not produce good eggs and I do not expect to have blastocysts, whatever is the fertilization. On the other hand, if the sperm is really bad, especially morphologically, so they really look 1 or 2 hours to identify a good morphological sperm to inject into the egg, then is a male factor because up to day 3, the embryos do develop with the machinery of the egg, and only after day 3 the embryo really becomes couple embryos. So both the female and male genetic do combine and do work together in order to divide into blastocysts. So many times we say that after day 3, if we don't have blastocysts, this is an indication of bad sperm. But on the other hand, we can say this, we do not say this, we do not claim this if the embryologist they see from the beginning bad morphology of the eggs. So you are really very young when you did this all this for IVF, and really only for blastocysts I do think out of 4 IVF is very bad number. I cannot give more explanation just out of these 5 lines of your message, but definitely you should do 1 or even 2 preimplantation genetic testing in your next 1 or 2 IVF, and only then to decide about egg donation or sperm donation. Do not decide right away after one abnormal genetic testing, let's say, because it might be only a coincidence of a bad cycle.
Excellent. Thank you so much for that, of course. And there is a thank you from Priscilla for you. Here it is. Okay, and let me have a look. 2 more questions are up, and next one is right here. Is there anything that can be done to improve the sperm morphology? Would you have any recommendations?
Definitely, with sperm, which might play around a little bit much easier. The first is because if the embryologist is really experienced, she or he can really choose a good morphological sperm. So one is the selection per se on the day of the ICSI. Other factors that we can improve is to do PIXI, and not so much IMSI, but PIXI. With PIXI, really do sometimes we select better morphological sperm. And of course, as you know, we can give some antioxidants to help the sperm morphology, but it's useless. And I laugh sometimes because if someone is still smoking and he's taking all these antioxidants, then it's really useless to take all this medication. There is no improvement of the sperm.
All right, excellent. Thank you so much for the clarification here as well. Next question is, so you talked about 9 possible stimulation in a year. Is it possible to go through it without pausing in between? What is the recommendation? How many time waiting between 2 treatments?
I talked about 9 natural cycle IVF in a year. So actually this is without any stimulation, so you can do it one after the other one. So this is for natural cycle. If you take gonadotrophin stimulation, then the optimum interval between 2 treatments is 2 to 3 months.
Perfect. Thank you for
More
this.
than 3 months is not needed. Less than 2 months, it might be wrong.
Okay, understood. All right. Next question is, so do you tend to get higher quality embryos with the short protocol than the long one?
Uh, I do not really believe that we have better quality embryos with any of these protocols. The best protocol is really the best for this particular patient, Maria. So from the studies that we have made in the same category, let's say in women less than 39, with both protocols, the percentage of embryos, of euploid embryos, is the same. So I don't think that there is any interference of the protocol with the genetic quality of the egg at the end.
And thanks a million for yet another question, of course, for your answer. And we will be slowly finishing, but someone is typing, so I just want to give it a second. Yeah, okay. Next question is right here. Might be our last question for tonight. What would the maximum size of follicle be at trigger?
Instead of answering that way, the optimal size of follicle to be triggered is between 17 and 20. This is the optimum. But on the other hand, doctors, one doctor measure a follicle 17 and the other measure it 21 and another one measure it 19. So really there is a lot of deviation from doctor to doctor. However, answering to your question, I think that a follicle more than 22 or 24 does not have a chance to produce a good quality embryo.
And amazing again. Thank you so much for the clarification to yet another question. And there is one more. Okay, there is a thanks from the patient, and there is one more question. Sorry, in regards to the mosaic embryos. So, can you explain a little bit more about those?
We did explain it a bit more earlier, Imad, about what is the mosaicism. So, mosaicism is that half of my hair are blonde and half of my hair are brown and another half of my hair is red. So I do not have all the cells in my blastocyst of the same genetic origin. Some of them are coming from the first division cell and they are all abnormal because this was abnormal, and some of them they are coming from the second division cell, for example, and all of them are normal. So having a minimal, let's say less than 10% of my cells being abnormal, it might be a normal situation. But having more than 50%, more than 40% of my cells abnormal, it means that the abnormal will win this war at the end, and this embryo is destined to die.
And thank you once more for explaining this. And what would be the reason for empty follicles or follicles that grow fast but the egg are not mature?
So 90% of the empty follicles, it's a mistake of the patient or the doctor or the injection of the ACG injection, the ovulation trigger injection, 90%. Only very rare do exist what we call empty follicle syndrome, repeatedly to have empty follicles.
And wonderful. Thank you so much. And as I mentioned, and now it seems that this is our last question. But of course, remember that if you have any more questions or you would like to get some more details, just go ahead and click on that link. There is an option to contact the team, Assisting Nature team. And of course, I'm sure they will be more than happy to assist you with even more details. And that will be it for today. So thank you so much for presenting, for answering all the questions, Dr. Papanikolaou. And of course, thank you to all of you for joining us over and over again. I know some of you are our frequent attendees, so thanks for that. And of course, for your excellent questions and definitely interesting ones as well. And as you can see, there are some thank yous coming up your way. Very interesting presentation. Some more thank yous as well. So before I let you go, anything you would like to add?
So what I would really like to add is that in the future, in the coming 10, maybe 15 years, I do believe that no embryo transfer will be performed without knowing the genetic quality of the embryo. But until that becomes reality, we really have to improve our techniques and to move maybe in a less invasive way in order to perform this genetic testing. Because why I believe this? Because every lady and every couple needs to have a less painful IVF treatment, and all the pain comes from the failure at the end. But the majority of the failures is because we transfer abnormal embryos. So if we manage to diminish all these useless embryo transfers, this will be an improvement. Even when I'm telling to my patient that even if you have one or two embryos and we decide to test it, yes, they might be abnormal, but once we get the result, you will get distressed for 1, maximum 2 hours. And at the end of the day, you will say, yes, we were right that we performed this test. It's much better this parodic, transient disappointment than getting a negative ACG result.
That's indeed truth. And thank you so much for commenting on that, of course, and your how you said that is just a wonderful ending, that's for sure. And as you can see, there is a comment, if only I knew you before my
And
12 IVFs.
I would like to ask Ros Cajuana to give us a call on Monday to just to discuss about her past before she moves to surrogate mother.
All right. Okay. And of course, I love your futurist attitude. Couldn't agree more, for sure. Thank you so much for those comments. And of course, as you
Have a
know,
good night.
Exactly. Everyone, wherever you are, have a lovely evening, have a lovely night, or have a lovely day. And well, you know that it has been recorded and it will be uploaded on our site. You will find it on myivfanswers.com, but also if you go to our YouTube channel, you know that there it will be uploaded there. And of course, you will be able to find some other previous webinars also with Dr. Papanikolaou. So just go ahead and visit our site. And of course, you if you go to Facebook, our Facebook page and Instagram, that way you will know that there are plenty of events coming up. And actually, next week we will have another guest from Assisting Nature, and this time it will be Dr. Robert Najdecki. So I can only encourage you and to register already for that next event as well on Friday. And once more, Dr. Papanikolaou, thank you so much for joining, for your expertise, for answering all the questions.
Good
It's
night,
always great to have
Caroline.
you here. And thank you also for your time. Have a lovely weekend, everyone. And I hope to see you on Monday, as always, as well. Thank you. Take care.
Bye.
Bye.